Broadcasting live from Houston, from the space city to the world. You are watching NowMedia Television.
Today in Pain Diaries, we have two very special guests, Dr. Jay Heintz from League City Spine and Sports, and Dr. Candice Burnette from Modern Pain. And we are talking about and answering all of your questions related to neck pain and whiplash. Thanks for joining us. I'm Dr. Suzanne Manzi, and this is Pain Diaries. More people are surviving cancer than ever before in the United States, according to a new report from the American Association for Cancer Research. In the past 3 years, the number of cancer survivors in the U.S. increased by more than 1 million. There are 18 million survivors in the U.S. as of January, with that number expected to increase by 26 million by 2040. The report notes that there were only 3 million U.S. cancer survivors in 1971. For all cancers combined, the 5-year overall survival rate has increased from 49% in the mid-1970s to nearly 70% from 2011 to 2017, the most recent years for which data is available. The overall cancer death rate, adjusted for age, continues to drop, with reductions between 1991 and 2019, translating into nearly 3.5 million deaths avoided. Don't shower during a thunderstorm. Since lightning can travel through plumbing, it's best to avoid all water during a thunderstorm. Do not shower, bathe, wash dishes, or wash your hands, according to the U.S. Center for Disease Control and Prevention. The risk of lightning traveling through plumbing might be less with plastic pipes than with metal pipes. However, it's best to avoid any contact with plumbing and running water during a lightning storm to reduce your risk of being struck, the CDC added. That's not the only danger when you're inside. Stay off porches and balconies. Don't go near windows and doors, and don't lie down on concrete floors or lean against concrete walls. Also, do not use anything connected to an electrical outlet, such as computers or other electrical equipment, the CDC said. Stay off corded phones. Cell phones and cordless phones are safe if they're not connected to an outlet through a charger. U.S. Task Force proposes recommendation to screen for anxiety in adults. The U.S. Preventative Services Task Force says for the first time that adults under the age of 65 should be screened for anxiety, according to a draft recommendation. The USPSTF is a group of independent disease prevention and medical experts whose recommendations help guide doctors' decisions. The draft recommendation is not final, but will now enter a public comment period. The panel found that screening for anxiety in adults younger than 65, and that includes those who are pregnant and postpartum, can help identify anxiety early. The task force defines anxiety disorders as characterized by greater duration or intensity of a stress response over everyday events. The anxiety recommendation would apply to adults 19 and older who do not have a diagnosed mental health disorder. The depression screening recommendations apply to those 18 and over who do not have a diagnosed mental health disorder and are not showing any recognized signs of depression or suicide risk. Did you know drinking at least 4 cups of certain teas may reduce type 2 diabetes risk? In my current studies, I have been reading that by 2030, 25% of the population will have diabetes. Drinking black, green, or oolong tea might have more benefits than a little energy boost. A certain amount could reduce the risk of developing type 2 diabetes, new research has found. Drinking at least 4 cups of any of these teas per day has been linked with a 17% lower risk of developing type 2 diabetes over an average period of 10 years, according to the research. Did you know women's health got worse in 2021? For women around the globe, the second year of the COVID-19 pandemic brought more health challenges than the first. In 2020, the medical technology company Hologic launched a global survey in partnership with Gallup to assess how well women's health needs were being met. Countries were scored based on women's responses to general questions in 5 categories: general health, preventative care, mental health, safety, and basic needs like food and shelter. The overall score for the Global Women's Health Index in 2021 was just 53 out of 100, 1 point lower than in 2020. No country scored higher than 70 points in 2021, with Taiwan, Latvia, Austria, and Denmark in the top spots. 3 countries scored fewer than 40 points: Afghanistan, Congo, and Venezuela. The United States landed in 23rd place with 61 points out of 100. Women were more stressed, worried, sad, and angry in 2021 than they were at any other point in the past decade, according to a Gallup survey that's factored into the Global Women's Health Index ratings. Women were also more likely than men to say that they didn't have enough money to afford food in 2021, a share that rose from 34% of women in 2020 to 37% in 2021. It's time for a commercial break. We'll be back with Pain Diaries. Welcome back. I'm lucky to have Dr. Jay Heintz, the chiropractic owner of League City Spine and Sports, here with me today. Dr. Heintz is a chiropractor with board certification in sports medicine. He's a certified chiropractic sports practitioner. He taught at the Texas Chiropractic School from 2005 to 2011, and he's on staff and the treating chiropractor with the Houston Dynamo since 2011. He's also whiplash and brain injury traumatology graduate of 2014. He's also dry needling certified, and I'm happy to introduce him as I'm the medical director of his office, League City Spine and Sports in League City, Texas. So, Dr. Heintz, tell me about your current practice and then about the Houston Solutions Network.
So, thanks for having me. Our office is a medically integrated chiropractic clinic. So we have nurse practitioners, we have chiropractors. Dr. Manzi actually comes in and does consults on pain management for our patients. So the advantage there is that we try to help our patients not get lost. We try to give them all the options that medicine has for non-surgical care in one spot. I'm also the medical director of a group called Houston Injury Solutions Network. And what that group is a group that basically pulls our resources to help become better educated on how to handle auto trauma. Unfortunately, in Houston, auto trauma is a very common thing, and very few doctors are confident enough and trained well enough to handle those cases. So we work with providers across many specialties to give our patients the best care possible.
Great. So can you tell me, HISN, the Houston Injury Solution Network, can you tell me a little more about some of the specialized technology that you have available, like the digital x-rays, to help patients be diagnosed properly as well?
Sure. So HISN has about 70 providers, and they have a huge number of specialties. And within that 70 providers, we've got lots of different treatments that help explain things that are otherwise unexplainable. So for example, one of the things that unfortunately can happen in an auto injury is a permanent slippage or a tearing of the vertebra, where the vertebrae slide in the neck or in the low back more than they should compared to an average person. The only way to see that is to shoot digital flexion extension views and then take those views and digitally render them with software to look for that injury. And why this is so important is if a patient has this, it really changes their prognosis. So we need to be able to communicate that well, and then that way we can give the patient a better understanding of what they're going to have to work with as far as the long-term prognosis of their injury.
Thank you, Dr. Heintz. I really have had great benefit from working with you and the other docs in the HISN group. It's great to have that network, to have people to refer to when treating these car accidents, and having the availability of all these different specialties under one umbrella so patients can get the right care that they need. Can you tell us a little bit about why do we see a greater amount of soft tissue injuries and collisions today versus 25 to 30 years ago?
Sure. So one of the things that I ask my patients occasionally, especially when they're struggling to understand how they got so hurt, is I'll say, okay, well, if you had a choice between being in a 57 Chevy Impala versus a 2021 Impala, pick your car. And 10 times out of 10, the patient goes 57, because it's a big old chunk of steel, right? But in reality, about 25, 30 years ago, the United States made this great idea. We're like, hey, we want less people to die in car accidents. So what they did is they really stiffened the cars up so that the body of the car is very much like a NASCAR car. So it's designed not to crumble, not to let the cab come in on the person. But one of the rules of physics says that force is always maintained. So if that crumbling effect is not occurring, that force is now getting transferred to the occupant. So what we have is less fatality, less people dying, but more people getting injured. And it's a trade-off. It's a good trade-off. But unfortunately, there's a greater amount of soft tissue and disc injury and facet injury than we've ever seen in cars previously.
Wow, that's pretty dramatic. So how are the auto collisions like sports injuries then?
So the way I look at it is trauma. So people who think and treat traumatic patients have a better idea of what we're dealing with, and usually it just means a bigger injury. Very routinely as a chiropractor, we have a patient who walks in and their neck hurts because they woke up from pain. Waking up because you slept through the signal to turn your neck is usually a very quickly resolving pain versus whiplash, which can take months and require a lot more specialized treatment.
Interesting. Yeah, it's definitely a challenge. So, our goal is to get these patients treated as soon as possible, so that way their injury doesn't become chronic. I know sometimes the insurance company tells people, I couldn't be hurt because the impact was minimal. Why do some people hurt so much when there was hardly any trauma or damage to their vehicle?
So that goes back to the comment we were making earlier about the changing cars. These cars don't have that crumble factor like they used to. So a very, very small impact can cause a significant injury. You mentioned earlier about some of the advanced training I have in auto physics, and that professor, or the person who taught that was a guy named Dr. Art Cross. And Dr. Cross used to actually put people in cars and strap on all this monitoring equipment, and they would physically just push the cars, like the engines weren't even running. So, you would think that with the engine not being running and physically humans pushing the car into a wall or into another vehicle, that the amount of injury wouldn't be that great. Well, when they got the preliminary data, they shut down the experiments because they realized that they were causing long-term damage to the people who were volunteering for the studies. So it can happen that in a very, very low impact, because the car is not crumbling, all that force transfers up to the occupant and the injury is significant.
Wow. I've heard, another analogy of eggs. When you're driving home from the store, and you have these eggs in a crate, and sometimes when you get home, they're crushed. So it's kind of the same scenario in that situation, where there's really not much, force or trauma, but with this high speed, and maybe if you stop short on the way home from the store, something like that, you can actually have these eggshells crush on the way home. And that can happen to our soft tissues as well.
Correct, and it also depends on the person. So just looking at the screen, if you look at your neck versus my neck, statistically speaking, women are at higher risk for auto injury and whiplash than our males. And it's just a body, it's shear mass, or shear mass, that's what I should say. So certain people are at higher risk. splendor females, especially seniors, significantly higher risk than, say, a 20-year-old linebacker.
Yeah, I can see the difference just looking at ourselves on the screen here. And I can imagine, some little old lady who has some arthritis already in her neck, and then she gets in a car accident. I mean, even though she had arthritis and didn't hurt before the accident, after the accident, it might be so severe because of the pre-existing arthritis, and then the ligaments and joints and discs can, be compromised just from aging, but then when they're subject to trauma, it can be even worse.
It makes the recovery from those injuries a lot more challenging. Back to, if we think about the example that you gave, most people, and I tell patients this all the time, in the old days, chiropractors shot x-rays on everybody that walked in the door, and we're now being advised that that's not probably the best practice. And the reason is because we're not 2020 model cars. So if we get a 40, 50, 60-year-old person that walks in, they're gonna have arthritis. We know that. It's not necessarily, the x-ray is not necessarily gonna change our treatment program. However, if you superimpose that arthritis on a collision, and now there's trauma to a less than ideal joint, it does take a lot longer and frequently requires more invasive medical care to resolve the injury than would a young, healthy, non-arthritic person, even though the patient was pain-free the day before they got in the accident.
Wow, that really does make sense now. I know a lot of the frustrations we find too when treating these patients is, when we see people, they're like, my primary care wouldn't see me. They just didn't want to help me, even though I was in this terrible car accident and I need some kind of medicine to get through this. Why do you see mostly the primary cares deny care when people are in a car accident?
It unfortunately comes down to insurance and protocol. So, you have to think your primary care, their normal thing is dealing with major medical insurance, Medicare, those types of insurances, and they're dealing with a vast array of injury. When it comes to auto injury, many times the major medical insurance will deny coverage. They'll say, hey, this wasn't us. This was somebody else's fault. It falls under a different policy. And since that isn't where most primary care physicians specialize, unfortunately, frequently the patient is told, we're sorry, you're gonna have to treat elsewhere. The issue is they're not typically told where else to go. They just say somewhere else, not somewhere else but here. And that was one of the things that we tried to develop with HISN is we actually have a zip code locator of providers who are willing to treat people regardless of how they're injured. Dr. Manzi and I are both of the opinion that we don't discriminate against patients from how they're injured. We just want to help them get better. So if you go to our website, you can actually go to the zip code locator and find a provider who is very well trained and knows how to handle these situations and can guide the patient both in the medical side, which is the most important thing, but also can help them navigate the insurance waters.
Yeah, I definitely find that in my patients, especially because they're already established with me as a pain management physician. If they're in a car accident and then they come to my office, of course I'm going to help them. Of course I'm going to help them navigate the waters of, being in an accident and how we can prevent this from being an ongoing problem for the rest of their life. We want to address the injury immediately, and more than happy to help them initially from the injury, help guide their treatment through their chiropractic care, physical therapy, if they need medications, and possibly even injections to help the pain after an accident. When I go talk to other primary cares too, I really try to educate them and say, I know you might not want to be involved in your patient's care, but I'm more than happy to help you. And I do offer the HISN website. And if they're close to me, I'm always happy to quarterback that patient's care, so that way they can get what they need in a timely manner. We definitely, again, like you said, we really want our patients just to get better. And again, we don't discriminate on the way they're injured. If they have an injury, we treat it. So let's talk about the type of providers that typically make up the medical team for these auto injury cases.
So typically, like you just mentioned that you will be willing to quarterback. That's rare that a specialist is willing to quarterback. So usually the quarterback is going to be primary care or chiropractic. And the reason behind that is just is access. So classically in our office, we can get patients in the same day. The higher you go up the specialty chain, usually the further out they're booked. So sometimes the patient has to wait unnecessarily. So usually it starts there. The initial exam is to rule out what we call red flags. So like, is there immediate need for an MRI or a trip to the emergency room, or something that has to happen right there? Once we rule out the red flags, we propose a course of treatment that's usually both conservative and medical. So medication plus conservative care chiropractic that usually runs for a period of time to see how the patient responds. Ideally, during that time, the patient gets 100% better, they're done. Very frequently, the patient comes in with 6, 7 things wrong, and we'll whittle that list down to 2 or 3, but we've got 2 or 3 that are being a little resistant. At that point, we usually get advanced imaging, usually in the form of MRI, and then an appropriate referral is made. So the referral will be based on what the MRI tells us. So if it's a disc herniation or a facet injury, it would go to an interventional pain management specialist like Dr. Manzi. If it's a shoulder or a knee, it will go to an orthopedic surgeon. If it's a brain trauma, it would typically go to neurosurgery. So we just let the image and the injury guide the referral process.
Definitely, and I'm really proud to be part of this network to help patients get better. Being board certified in electrodiagnostic medicine as well as pain medicine, I'm able to provide the diagnostic treatments with nerve studies for any kind of numbness, tingling that might be coming from the spine or the wrist, to diagnose carpal tunnel versus a pinched nerve from the neck or the back down to the toes or hands. And then from a pain management standpoint, if the patients just don't get better with their typical conservative care, I really sometimes have to evaluate them more seriously for specialized injections into the joints or over the nerves that are caused from disc herniations and or whiplash type injuries.
So you mentioned the electrodiagnostic studies. One of the things that we found, and again, we've already discussed, Dr. Manzi is our medical director because we really wanted, we begged her to come be our medical director. But when she does an electrodiagnostic study, it's a little different than when we've ordered from other people, because historically there's a tech and they capture the data that goes up into a cloud and it's read by a doctor, but the doctor's not in front of the patient. She actually performs her own tests and does the readings herself. So she's got one-on-one contact with the patient, and we find that the false negative on those tests goes down just substantially. So we get a lot better data having the physician perform the test than having a tech perform the test and the physician not be present in the room.
Yeah, being part of the Electrodiagnostic Society and being board certified in electrodiagnostics, I try to do what's best for the patient as if that patient was my cousin, my brother, my sister, my aunt, my uncle, my mom, or my dad. I really want them to have the best treatment. And I've found performing the study myself doesn't take much more time, and the patients get the diagnosis that's medically necessary and the treatment that's deemed appropriate from those tests. So I do enjoy doing the electrodiagnostic studies, and it's been great to be part of League City Spine and Sports Medicine in League City as the medical director to allow greater access to these patients. And we do accept, referrals from any other doctors that are willing and needing their patients to be treated and worked up properly. So let me talk a little bit about your actual practice, League City Spine and Sports. As the medical director, I'm overseeing 2 of your nurse practitioners that do well care and medical weight loss. Can you tell me a little bit about them and how that's incorporated into a chiropractic office?
So absolutely, because we deal so much so the way we describe our practice is if you have musculoskeletal issues, challenges that are not responding, and you don't need surgery, that's where we fall in. So in the old days, the chiropractors were like, hey, don't go see the medical doctor, and the medical doctor's like, don't go see the chiropractor. And actually now the American Medical Association says, hey, if you have mechanical back pain, so back pain, inside the back, that the first referral should be to chiropractic. But there are many times when the patient comes in and they're just in too much pain, and they need something to get them there faster. So what our nurse practitioners typically do is, like, if the patient's in extreme pain, is they'll do things like trigger point injections, or they'll do an injection into the glute to just drop that pain level down so that we can be more successful with our job. A lot of times in physical pain, weight is a huge issue, especially here in Houston. So it's something we all struggle with. My high school nickname was Skinny. It wasn't a compliment. So it's something we're all dealing with. And, you know, historically, we always approach from the chiropractic side just straight diet, nutrition, which works, but it's hard, especially as we get older. So what our nurse practitioners do is they kind of bridge the gap there, and they can help the patient with medication if necessary, but then really get to the diet and nutrition and the underlying cause of the inflammation so that they have an exit strategy from the medical weight loss. And that's what makes me really proud of that program, is that we are trying from day one to get fired. We want to allow the patient to achieve their goal, but then have a strategy where they're not dependent upon our team. The other part of that is bioidentical hormones. So the nurse practitioners, again, I'm a chiropractor, so this isn't my part of the practice. This is the part of the practice that Dr. Manzi actually directs. But our nurse practitioners can evaluate people hormonally to see if the hormones are the reason that they're not succeeding in achieving their goals. So, you know, the way I tease patients is, we know statistically speaking that we're going to live longer than mom and dad, but the 20 years we're buying aren't really great. And this generation that's now in their 40s and 50s has an opportunity to try to cheat father time a little bit, to feel better, to get better gains out of their out of the time that they spend in a gym, out of the time that they spend on their diet, to just be more vibrant by exploring the option of hormone replacement therapy.
Yeah, it's been great working with them and going to the training together with them. You know, obesity is rampant. You know, over 40% of the American country is obese. It's a scary number. And it is a hormone disease. It's a disease related to hormone imbalances. And the fact that we could now tweak those and allow patients to run a clean engine in their car, in their body, and help with the weight loss. Because again, long term, you know, we're living longer and we need to be healthier to take care of what we need to take care of. You know, that's my goal for this show, is to educate people on how they can keep their business running, keep themselves running. And, you know, living longer and being healthy is a huge part of it. And we're just here trying to educate everybody. But to be fired is actually a compliment. Once these patients reach that level, they don't need us anymore. We've done our job. And then they can tell their friends and family and then refer them over, and we'll get them treated just the same way, you know, with all the care and compassion that they deserve.
It's a very common thing that we hear. You know, patient walks in, she's late 40s, early 50s, and just is like, you know, I know, I've been told like this is as good as it's gonna get. And that's not the case in modern medicine. Don't get me wrong, they typically have diet things they need to work on. They have exercise things they need to work on, and we're gonna point those out. But when they're hormonally in the tank, or adrenally in the tank, as we call it, it just makes an unfair playing field for them. So they're fighting an uphill battle, and that's not necessary any longer. There's ways around that, and then all of a sudden, the things that they tried 2, 3, 4 years ago work. So there are ways around it, and the patients can, you know, lose that weight, gain that muscle mass, and that's a big thing. If we can encourage patients to increase their muscle mass, we know that they're going to lead longer and healthier lives, just by being stronger.
Absolutely. You know, the recommendations are now, you know, at least 2 to 3 times a week of strength training. And it doesn't have to be heavy weights. You don't have to be a weightlifter to do strength training. There's just basic exercises that can be done, providing resistance, you know, and if it's just where you need to start, you know, that's where, you know, your office comes into play, and other chiropractic and therapy offices can come into play to help patients learn the ropes. Do I just need to start with an exercise band, or even body weight? You don't need to be pushing metal up and down in order to strength train. And I think there's a big misunderstanding about that. But that helps the metabolism tremendously, and I'm a huge proponent of it. You know, I've been lifting weights since I was 14, and you know, it's been a long time, and I enjoy it. But some people don't, and if we can just educate and provide them with fun ways to incorporate that into their lifestyle, we're on the right path.
Yeah, and that's a big thing, is finding the thing that they like. There's so many ways to be physically active and fit that there's not a perfect. We know that there should be some endurance, there should be some cardiovascular, there should be some weightlifting, and there definitely should be some flexibility. So in our office, we generally tend to have to get our guys to become more flexible and our females to focus more on the weights, because that's the corners that they like to train into.
Yeah, it's so true. I know a lot of people, females that I see, they're like, oh, I really like my Pilates class. And Pilates is great. I mean, you're getting some resistance with band type activities, but it's not the same as actually, you know, potentially lifting heavier weights. But it's a great bridge to, you know, bridge the gap on, you know, getting into something you enjoy. And hey, if Pilates is what you enjoy, that's, at least you're getting some resistance training. But muscle is muscle, and the length of the muscles, the length of your muscle and the length of my muscle are independent of our bodies. And you know, there's certain exercises that aren't necessarily going to change the shape of your muscle or lengthen them. It's just all about loading the muscle so your ligaments can be put at a stressful force, which then allows your bones to be built. And that's also where the hormone therapy comes into play. You know, we are able to, you know, treat osteoporosis. There's just so many amazing benefits of the hormone therapy with regards to the weight loss and the overall wellness of bone health, cardiac health. And, you know, to have a whole team behind the care of these patients, it's just really cool. I love working with your nurse practitioners and your office, and, you know, you have 3 other chiros in your office as well. So it's a good orchestra for patients to get the care that they need.
You mentioned earlier, we've been on staff with the Dynamo since 2011 and the Dash pretty much since inception. And we've tried to model our team very much like the medical team that we work with at those events. You know, when we go into those events, there are specialists for almost anything you can think of. And each person contributes a piece. And the athlete, the professional athlete, wins. So we try to do the same thing in our office, where we've got multiple specialists thinking about the same thing. We're constantly going into each other's offices saying, hey, I've got this challenging case, or hey, what do I do? When Dr. Manzi comes in, I typically have a list of 3 or 4 people that I'm like, hey, I'm worried about this. How would you do this? So the patient is getting, you know, unfortunately, especially in my profession in chiropractic was always practiced in a little box, but with one person at a time. And medicine in a vacuum, to me, is scary. I really love medicine in an environment where there's collaboration and thought, and even every person on our team knows that, like, all of our MAs and CAs, so all of our assistants know, like, if you've got an idea for anybody, bring it up. We want to do what's best for the patient, and everybody check their ego at the door so patients get better faster.
Awesome. Well, I'm really happy to be part of your team, and I really enjoy working with you guys. Thank you so much for being here. Again, Dr. Jay Heintz with League City Spine and Sports, and I'm Dr. Suzanne Manzi with Performance Pain and Sports Medicine. Feel free to reach out to us. We're happy to help. This is Pain Diaries. We'll be back from a commercial break shortly. Hi, welcome back to Pain Diaries. This is Suzanne Manzi with Performance Pain and Sports Medicine. I'm going to talk about neck pain and whiplash. I know we've already spoken a little bit about this, but whiplash can happen at the time of an injury. When the neck moves forward and backwards, or even side to side at rapid speed, we have no control. This can cause pain as the soft tissues become injured. Physical exam is usually what's required to diagnose whiplash. So usually when seeking consultation regarding neck pain, we start with a range of motion in the neck. We range the shoulders, the neck, evaluate the degree of motion that causes pain, especially side to side, up and down, and lateral bending. We really need to see where the tender areas are in the neck and shoulders and down the back. It's always important we test reflexes, strength, and sensations in your limbs as well to evaluate for a worse injury. If you happen to go to the emergency room or urgent care after suffering whiplash, usually you get imaging studies as x-rays or CAT scans are available. These make sure there's no fractures in the bones. X-rays can also show if there's any kind of dislocation or arthritis present. Higher tech x-rays are also available, which can detect if there is ligament laxity after an accident. Ligament laxity after an accident can cause significant persistent pain, and these x-rays can evaluate your prognosis after a whiplash injury. These x-rays can also become important in the treatment of your whiplash. A CAT scan requires more intense examination as it's specialized. It's a series of 3D x-rays used so we can see cross-sections of the bones. CAT scans can identify if a fracture is not identified on a regular x-ray. The highest level is an MRI. This uses a magnetic field to produce a 3D image. MRIs can detect the soft tissue injuries such as the muscles surrounding the neck, the ligaments, the discs, as well as deep inside to look at the spinal cord. Treatment of whiplash is focused on restoring you to your normal function. The goal is to control the pain and restore the normal range of motion in the neck. Treatment depends on the extent of whiplash injury. Some people only need over-the-counter medication and home care. Other people might need prescriptions or specialized treatments with chiropractic care and/or physical therapy. Usually, rest the first day or two after the injury is indicated, but too much bed rest can actually delay recovery. As a pain management doc, I do prescribe cold more than I prescribe heat in the setting of an acute injury. Cold packs applied to the neck every 20 minutes per hour can help reduce inflammation. Heat brings in inflammation, so I try to tell my patients suffering from whiplash to avoid heat in the acute phase. Sometimes over-the-counter medications are also indicated. Prescription medications may also be necessary if there's a component of nerve pain or other more severe pain that's not responsive to over-the-counter medication. Sometimes muscle relaxers for short-term use are also helpful to loosen the tight muscles and soothe the pain. Unfortunately, some of these medications can make you feel sleepy, but it might be useful to get a good night's sleep in the beginning of an acute injury. Sleep is important for healing. Usually, if the whiplash persists for 2 to 3 months, even after conservative treatments, and the pain just doesn't get any better, sometimes injections are indicated to help reduce the inflammation. Again, as a pain doctor, this is when referrals come from a chiropractor or physical therapist. For whiplash, injecting the joints sometimes does wonders for people. Just a small dose of steroid and some numbing medication reduces the inflammation in these joints and is able to restore patients back to normal function with much less pain. They also allow people to participate fully in their exercises at therapy and restore their range of motion and function. As with any injury, exercise is the best medicine. Usually we prescribe a series of stretching and movements to do at home. When treating with a chiropractor, passive modalities with gradual ease into active modalities are usually the treatment strategy. Passive, meaning the doctor does the treatment to you. Sometimes you lay on a table, you have decompression treatments, electric modalities such as a TENS unit or muscle stimulation can do the trick. The goal of exercise is active. It's to restore the range of motion and get back to normal. Usually before the exercise, sometimes heat's indicated to warm up those muscles to allow you to get the most out of your exercise. Usually we start with rotation of the neck, tilting your head and bending your neck towards your chest, rolling the shoulders. With ongoing whiplash, sometimes assistance with these range of motions are helpful through physical therapy and chiropractic care. The goal is to guide through exercises to strengthen muscles, improve posture, and restore normal movement. The number of physical therapy sessions with either the therapist or chiropractor may vary based on your injury. A customized personal routine that can be done at home is always advantageous. Years ago, people used to wear foam collars. These were used for whiplash in order to hold the neck still. However, studies have shown that keeping the neck still for too long can actually decrease the strength and interfere with recovery. Usually we don't suggest using a collar anymore unless it's no more than 72 hours after the initial injury, and not more than 3 hours a day for a few weeks. Follow up with a physician or chiropractor is indicated and should be followed up closely if a foam collar was recommended after the initial injury at the emergency room or urgent care. All in all, whiplash injuries should be short and not progress to chronic pain as long as you receive the right treatment up front, initially after the injury. Don't hesitate to reach out to us at Performance Pain and Sports Medicine, 346-217-1111, or email info@performancepain.com. Or call your local chiropractor. Unfortunately, as we've already discussed, your primary care might not want to be involved with your whiplash injury. Just know, you always have a trusted source if your primary care doesn't want to be involved in your care after suffering whiplash. Some quick facts about whiplash. Only about 22% of auto injuries occur when impacts were greater than 12 miles an hour. 60% of injuries happen in car accidents with low speeds of 6 to 12 miles per hour, and yet another 18% received soft tissue injury when impact was less than 6 miles an hour. Most cars can withstand a crash of 8 to 12 miles per hour without any damage. More than half of all whiplash injuries happen without any damage to the vehicle. An individual may have some pain immediately following a car accident, but whiplash symptoms may not occur for hours, days, weeks, or possibly even months. Statistically, women experience whiplash more than men. This is primarily due to the fact that men have stronger neck muscles and women have smaller neck bones. Poor posture at the time of an accident can worsen the whiplash injury. If you're in a car accident, you should be checked out as soon as possible by a chiropractor or physician. You may not realize that you've sustained an auto accident injury. Whiplash can improve with chiropractic care, as well as medical care. It's time for a commercial break. We'll be back with Pain Diaries in a few. Welcome back to Pain Diaries. I'm so excited to bring you my dear friend, Dr. Candice Burnette, medical doctor with modern pain. She's an interventional spine specialist, just like myself, who practices in Sugar Land, Texas. Dr. Burnette and I have known each other since 2012, and we have a funny story of how we met. And for the past 10 years, we've been working together, collaborating. Our friendship has blossomed over the years, and we started out way back when, going to dinner once a month, and we continue to do so with our female physician group here in Houston that we used to call ourselves the Pain Girls. So Dr. Burnette, thank you so much for being here with me today. Let's first talk about how you got into pain management.
Sure. Hi, Dr. Manzi. It's great to be here. Thank you for having me. I know it seems like those days were so long ago,
For sure.
but it's definitely a good time. But my story starts, I think, back in med school. I actually had a difficult time figuring out what specialty I wanted to be in. So I knew a couple of things. I wanted to work with my hands and do procedures. I enjoyed forming relationships with patients, so I wanted continuity of care. But also I wanted to treat a wide range of issues. So it was really like the Goldilocks and Three Bears of figuring out a residency for me. Either I could do a lot of procedures, but there was no follow-up with my patients, or there was continuity of care, but only a very narrow scope of issues to treat. So that's when a friend told me about PM&R, Physical Medicine and Rehabilitation. And at that time, I had never heard of the field, but I looked into it, and it did check all those boxes. So I ended up doing my Physical Medicine and Rehabilitation residency in Mount Sinai in New York City. And it was there that I did a pain management rotation. And that's really what sealed the deal. It checked all those boxes, but also it was so gratifying seeing how treating patients with their pain and effectively getting them some improvement really impacts their lives and the lives of their loved ones. So I was sold. And I did my pain management fellowship at Eastern Virginia Medical School in Norfolk, Virginia.
Awesome. Our stories are kind of similar about physical medicine and rehab, which I told on a prior Pain Diaries episode. Yeah, I love it too. You know, you get that continuity and you can do procedures and, you know, you just get to know your patients. And it's a great field, and we're definitely, you know, in that forefront of this field. And being physicians, female physicians, we're in a minority. You know, we're only about 17 to 18% of the pain management docs out in the United States. And so, you know, I feel like we have a great approach as females to the field of pain management.
I agree.
So tell me about your practice. I know initially you were, you know, with the larger group, and now you've transitioned into the private world. Tell me a little bit about that.
So I was with a large group of orthopedists, being the only pain management physician for about 100 different orthopedic specialists. And recently, actually during the pandemic, I joined a private pain management group. It's called Modern Pain Management, and we have 2 locations in Memorial City and Sugar Land, Texas, and there are a total of 4 of us. So I really love it. I work with a great group of individuals, and I have the support there that I need. And I feel like my career and practice has really blossomed since joining the group. It will be 2 years ago, September 1st actually, it was 2 years.
Wow, 2 years already?
Yes,
I can't believe how fast that's gone.
I know, it really does fly by, especially when you're having fun, right?
So I know we do have a good time at work because we're helping people. We're getting them better. Tell me what most excites you about the field of pain management now.
Kind of a few things. One is all the innovations since when I started over a decade ago, and you as well, and the advancements in technology. We're really in an exciting space right now in pain management with the ability to perform proven effective treatments that broaden our scope to reach more patients in pain. And a lot of these procedures and treatments that we can offer are minimally invasive and safe and low risk. So it also offers patients treatment options that are non-surgical. And I think that is really huge because, like I said, it reaches more patients who are suffering.
Absolutely. I know way back when we started, you know, what did we do for those poor patients that had total knee replacements 10 years ago? I mean, we would have to give them some medicine, and then that was really about it. Now there's just so many more advancements that we can do that are minimally invasive. Even though the orthopedic surgeon says, hey, your hardware looks great, your knee, everything's fine, why are you still in pain? I don't know. Well, 30% of knee replacements potentially still have pain. And so the technologies now have advanced tremendously. And that's just one example. You know, we have 5 or 6 different treatment modalities that we can do to help these patients.
It's so true. Isn't it amazing to have these options at our disposal now? I mean, we really have come a long way.
Yeah, the field is definitely advancing. And the cool thing is, you know, each doctor can follow their own path. As a pain doc, you know, some people just might be more comfortable doing the basic bread and butter pain procedures. And that's great, if doing what you're comfortable. Some other doctors, you know, kind of like us, we're more willing to further train ourselves and take on that advanced technology. The minimally invasive procedures now are, you know, endless compared to what it was 10 years ago. We didn't even have some of these options available to us.
Definitely keeps us on our toes too. It never gets dull, which I also love.
Absolutely. And speaking of that, I know we both like to teach, and I know you've been participating in teaching fellows and residents and even other doctors in the field. What's your favorite thing to teach about?
So, great question. Actually, it kind of piggybacks on where pain management is now versus 10 to 12 years ago. I remember in training going to as many courses as I could, the society meetings, cadaver courses like you mentioned, and seeing the same people on stage and in the room. In fact, there were times where I was the only woman in the room or the only person of color in the room. And I think we have advanced so much since then as far as diversity. You know, our patients come from all different backgrounds and have different lifestyles. So it's so important that leadership and practitioners in the field can offer a variety of perspectives and hopefully reaching more of these patients. So I really just love teaching anything, but especially anything that is a procedure that is a little invasive. I really enjoy that as well. But just really being able to share my story and share my practice with a group and hopefully, have them get something out of it. That's really what I enjoy about it.
And that's why I had you on the show today. It's just an exciting field. We're all excited about it. You're excited about the field of pain management. You're excited about advancing the field, just like I am. And we share the same vision for our patients. Can you share a memorable patient story with us?
Yes, of course. So one that sticks out immediately is she was about a 60-year-old woman who I saw in 2019. She came in because she had been suffering with years of chronic low back pain and leg pain. She had tried so many different therapy options, physical therapy, injections. She had even had surgery, and she was still in excruciating pain. Why she's so memorable is because when she came in, she just looked defeated. And I think she was really skeptical about what, if any, options I had to offer. So when we talked and, we decided what treatment options were available, we chose spinal cord stimulation. And she did fantastic. She's also memorable because her goals were so minor. They were so simple. She wasn't asking to start to bungee jump or skydive, or run a marathon. She wanted 3 major things. She wanted to be able to play with her grandson. She's a primary caretaker and he had special needs, and she wasn't able to do all the activities with him because of her pain. She wanted to do her art. She was an artist. She made jewelry, and with her pain, she was unable to do that, and that was really her passion. And then she just wanted to be able to do household chores, and I don't think that was asking much. So with the spinal cord stimulator, a minimally invasive treatment options for patients with chronic pain, her pain was 70% relieved. She was playing with her grandson, swimming, playing on the playgrounds,
Wow.
Things she never thought she'd be able to do, and she was making and selling her jewelry again. So definitely a success story there.
Oh, absolutely. Yeah, it's
one of many, by the way.
one of many.
As you know.
I love sharing these stories. It's really great, and we're so blessed. We can change people's lives for the better. There's such a stigma around pain management, and we're not just the docs that give out pain meds. I still have people come to me and say, "Oh, I was scared to come here because I was afraid you're going to give me medicine." Well, there's other medicines we can give that don't necessarily drug you up or make you feel funny. Again, spinal cord stimulation is one of those things where we treat with electricity. I mean, the technology's come so far over the past 30, 35 years, and we're just so lucky that we can share these technologies with our patients.
I agree, completely.
Yeah. So Dr. Burnette with Modern Pain in Memorial City and in Sugar Land, I really am grateful to call you my friend, my colleague, and I'm so blessed that you're here on this show with me today. Thank you so much for being here.
And thank you for having me. It's fun.
Absolutely. So
I'll see you at the next pain dinner.
Absolutely.
Okay.
We'll see you then.
Sounds good. Thank you.
So thank you, everybody, for tuning in this time to Pain Diaries. I'm Dr. Suzanne Manzi at Performance Pain and Sports Medicine in Houston, Texas. 346-217-1111, info@performancepain.com. This is another episode of Pain Diaries. And remember, take care of yourself so you can take care of business.
This has been a NowMedia television feature presentation. All rights reserved.